request Dr. Aditya Sharma to present management strategies anti-VEGFs versus intravitreal steroids.
Thank you very much, Dr. Neha, and good morning to all. I'll be discussing about the management strategy of retinal vein occlusions, mainly anti-VEGF and intravitreal steroids. As we've learned by now that RVO is a vascular disorder leading to retinal edema and ischemia due to venous blockage. And the main culprit here is Vegf molecule, which is a key driver increasing vascular permeability and neovascularization. Also, the ongoing inflammation exacerbates the damage, leading to increased macular edema. The vision loss experienced by the patient is primarily due to macular edema, thereby requiring targeted therapy. Anti-VEGF therapy, which is considered the first-line treatment these days, acts by inhibiting VEGF molecule, thereby reducing vascular leakage and neovascularization. The common molecules we use are ranibizumab, aflibercept, bevacizumab, which is used widely but off-label use, and the new drug approved is faricimab. The clinical trials of these drugs have been listed here. What we follow is the initial loading phase in which we give monthly injection for 3 months, followed by maintenance phase. In the maintenance phase, we have two options. First is PRN, that is pro-rata or as and when required, and the other is treat and extend approach. Of course, there are some long-term considerations, like some patients may require indefinite injections, and switching agents may be necessary in case of non-responders, like less than 10% reduction in central retinal thickness after 3 injections. These are quite effective in improving the visual acuity of the patient, mean improvement of approximately 15 letters in cases of CRVO and BRVO, and leading to significant reduction in the central retinal thickness on OCT imaging. Of course, all good things come with certain limitations. Here the limitations are frequent injection that adds on to the treatment burden of the patients. Also, some patients may exhibit variable response, like some may show partial response or some may show inadequate response. Also, the adverse effects like conjunctival hemorrhage, mild discomfort can be there, and rarely endophthalmitis can be seen. Coming to intravitreal steroids, these are alternative and adjunctive therapy that act by inhibiting inflammatory molecules, reducing vascular permeability and macular edema. Common agents we use are dexamethasone implant Ozurdex and triamcinolone. Dexamethasone is a slow release implant effective for up to 6 months, and triamcinolone is used off-label in cases of RVOs. Clinical trials that support this steroid use are SCORE and Geneva trials, as discussed by my colleague, Dr. Rahul. Ozurdex is given every 4 to 6 monthly based on the patient response. Triamcinolone is given in the similar way in 2 to 4 months. And combination therapy can be considered in refractive cases and in cases of central retinal thickness more than 500 microns and with neurosensory detachment. Steroids are also effective in reducing macular edema and improving visual outcomes, and the results are comparable with that of anti-VEGFs. But the duration of effect is usually longer than the anti-VEGF injections. And some other routes through which steroids can be given in RVOs are posterior subtenon injection or PST and suprachoroidal triamcinolone acetonide implants. Of course, as we can expect, intravitreal steroids do have some side effects like cataract formation and elevated intraocular pressure that can lead to glaucoma. The mechanism of action, duration, side effect, and the patient profile helps the clinician to decide the modality to go with. So these are the parameters we need to look for when choosing the modality of treatment. So when do we choose anti-VEGF and steroids? These are anti-VEGFs are the first-line drugs these days and are recommended for most RVO patients. These are ideal for young patients and those without contraindications to the drug. And on the other hand, we have steroids that are used as adjunctive drug and useful in non-responder cases to anti-VEGF and considered for patients who need longer lasting effects and fewer injections. This is a case of a 55-year-old male with CRVO. We gave monthly doses of razumab injections, 3 doses, and the patient responded really well to the drug. The second case of a 54-year-old female with BRVO, we had to give anti-VEGF for 3 months, and then we switched the patient to dexamethasone implant Ozurdex. and you can see how well the patient responded. Coming to combination therapy, these target both the Vegf-driven and the inflammatory pathways. And these can be given like initially anti-VEGF and then steroid, or both the drugs can be given simultaneously. Coming to future developments in RVO treatment, we have sustained release implants, Verisome, which is a sustained release drug delivery system, and with triamcinolone have been tried for RVO patients. Biosimilars like Razumab, Yesafili, and Opuvez have been recently approved. And these are the various therapies that are in the pipeline. Tarcocimab and Vorolanib, Bevacizumab is being considered on label now. Coming to patient education and compliance, which holds really an important place as most of the cases have metabolic disorders. So the importance of regular follow-ups have to be emphasized as clinicians to the patients. Also, the side effects that can occur have to be managed appropriately, and lifestyle modification, which is the most important thing. So the key takeaways are anti-VEGF is the first-line treatment for RVO patients. Steroids via various routes provide an alternative in refractive and chronic cases. Combination therapy can be effective in select cases, and the new emerging treatments improve long-term management.